I am patient advocate E. Dennis Broad. I've been a patient advocate for a number of years. I have counseled hundreds upon hundreds of cancer patients in various cancers, but principally in prostate cancer. I am not a physician. I am a volunteer in cancer support. I'm a support group leader, and I'm a patient advocate, and I'm active in various institutions. But what I say to you today is not medical advice and should not be taken as such. The only time you should ever make a decision or take any action, as I tell all the patients I've counseled, and this is my own personal opinion as an advocate, is after you've conferred with your physician and your treatment team. And that is how you make decisions. So I'm going to go and give you this as briefly, as simply as I can. No big charts, no fancy drawings and diagrams, just the way I tell it at support group meetings and in talks that I give in response to questions that people have asked me through the years. The GLEASON score is a way of rating the severity and aggressiveness of the cancer that you have after you're diagnosed with prostate cancer. This started in 1962, a long time ago, when there was very little science on prostate cancer. And I'm happy to say that we're making a lot of progress now. We were very late catching up with this, and we are doing very well in new developments in drugs and modalities for prostate cancer treatment. But at that time, there was very little, and it was very difficult to communicate to the patient how severe his case was, and for one physician to communicate to another physician. And for that matter, the pathologist who's reading the results of the biopsy to even tell the physician exactly what the severity was of the disease. So Gleason said, I'm going to find a way to rate these cancers that are being diagnosed. Well, how do you do that? Well, even just looking at the cells, you have to have a biopsy. You need actual tissue from the prostate gland. And that is done typically with a needle biopsy. Years ago, they used to take 6 random, that was the typical thing, was they would take 6 random samples. We call them cores from the prostate gland, and they would examine each one of them. They could be missing other things, but that's what they did. Now they take more cores, more samples, 8, 10, 12, 14, and now they have some techniques to make the selection of the area for the needle, for the biopsy, more accurate. They have MRI-guided biopsies and these fusion biopsies. You can do a transrectal ultrasound biopsy, and these tend to be more accurate, not in terms of identifying the cancer, but in finding it where it is within the prostate gland. So Gleason looked at the cells in the prostate gland, and he found that prostate cells had certain characteristics when they were normal, and then they had other characteristics when they were abnormal. And he saw some abnormal cells within the prostate gland. And if they were, and he wanted to rate those or label those so that he could identify those later. So what he found was there were 5 basic categories of these cells, and he called them 1, 2, 3, 4, and 5, oddly enough. But, how did he do that? Well, he found that the ones were slightly abnormal. That means they deviated from the normal prostate gland cell, somewhat. The 2s, more. They deviated more. The 3s, even more. The 4s and 5. So on. So this is how this came about. And then he made a really interesting discovery. He saw that the 1s and 2s, although abnormal, weren't cancerous. They did not have the characteristics of cancer cells. Thus, they did not carry prostate cancer cells, and they weren't in any danger of doing anything in the future to anybody. They would just be abnormal cells that would be in the prostate gland, and they were benign and they caused no problems. So he was left with 3s, 4s, and 5s. So now you're doing the biopsy, you get the cells, you get the samples, you look at the cells on a slide, that's how they look at them. And he saw that there were very often multiple kinds of cells on the same slide, coming from the same sample. So he's not concerned with the 2s and the 1s, but he is concerned with the 3s, 4s, and 5s. So he saw that some were more different levels, 5 and 4, 4 and 3. So he said that what we would do is take the two biggest. If 4 was the highest number of those cells, and then 3, you take those two. You ignore the 2s and the 1s. If a 5 and a 4, it would be a 5 and a 4. If it was more 4 than 5, it would be a 4 plus 5. Why do I say plus? Well, here's why. Because if you have a GLEASON 7, someone tells you you have a GLEASON 7, if it's a 3 plus 4 or a 4 plus 3, there's no way to really communicate that except saying a 3 plus 4 or a 4 plus 3. You want to keep everything consistent. So in order to be consistent with a number, GLEASON said you just add together the 2 largest kinds of cancer cells. So if you have 4 plus 3, those are the 2 most that appear in that sample, that becomes a GLEASON 7, and so does a 3 plus 4. If you have more 3 than 4, that's a 3 plus 4, that's a 7. You would do the same thing with a 5 and a 4 for a 9, or a 4 and a 5 for a 9. Well, what about these GLEASON 6? How do I get a GLEASON 6? Someone may ask, when I only have 3s. Well, what you have to do to keep it all consistent, to get one number, is you have to just add the 2 3s together as if they were the first and second most cells in that sample. So 3 plus 3 is how you get your GLEASON 6. You got basically all 3s. 3 plus 4 or 4 plus 3 is a GLEASON 7. 4 plus 4, all 4s, GLEASON 8. 4 plus 5, 5 plus 4, GLEASON 9. And 5 plus 5, GLEASON 10. Okay, that is basically the whole thing about the GLEASON score on how they rate the cancer. However, there are some things that you should know, a couple of nuances. First thing is this, that in a 3 plus 4 or a 4 plus 3 in a GLEASON 7, there is a difference between 3 plus 4 and 4 plus 3. A 4 plus 3 is more aggressive and more serious than a 3 plus 4. But another thing is that within that formula that has been completed, you have a percentage of each of those cells that comprise the core. And very often when you get a report from the doctor, it doesn't show you the percentages, so you really have to seek the report from the pathologist directly. And I'll tell you why. Let us assume you have a 3 plus 4, 7. If you have 99% 3 and 1% 4, that's pretty good. That is not really severe. But if you have 51% 3 and 49% 4, you can see you have a lot of 4s. They're almost equal. Same thing with the 4 plus 3. If you have 51% 4 and 49% 3, you don't have that many more 4s than 3s. That is considerably less severe than if you have 98% 4 and only 2% 3. So that's something you have to know and see if you can find out that from your physician. Another thing is this. Because pathologists are looking at these slides to make a determination of what these cells are, the cells don't come with the labels that GLEASON gave them. They don't say I'm a 5 or I'm a 4. They have to be interpreted, and that is subjective. So the pathologists sometimes have cells that are very close to being a 3 or 4, and they have to consider a call on their judgment. That's what they do. So it has become very common for cancer patients, prostate cancer patients, to have their slides read by another pathologist at another institution. This is very common, and your healthcare provider will participate in this with you and help you get it done. And sometimes they change the GLEASON scores on these things. Most of the time, these pathologists all over the world are pretty close because they're very well trained and very well educated. But sometimes it's not the case on some of these that are very borderline. So it's worth doing that. At any rate, that is about it on the GLEASON score. There's some other complicated things that are not necessary to discuss right now, and perhaps I'll be covering them in some of my other videos on prostate cancer, which I hope you will look for in this series. So at this time, I just want to wish you the best of luck in dealing with your disease.